The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you. Hope everybody's having a great end of the summer. Recording this on Labor Day weekend. Hope everybody's having a great Labor Day. Kind of the end of summer, the start of the fall year. As I said on the last podcast, the fall year is my favorite time of the year. You know, don't really look forward to the winter, but I love the fall. I love the fall temperatures and enjoy being outside in the cool temperatures. Today I want to do a literature-based kind of podcast, kind of looking at a review article I came across. Before I do that, I just want to thank everybody for just all the great emails, all the kind words, all the great tweets that everybody has been sending out based on the new book we just released, Ventilator Management, A Pre-Hospital Perspective. Just overwhelmed by the support and the outpouring, the great feedback on the book. Just want to thank everybody from the bottom of my heart. It's been a project I've been working on for, like I said, a couple years, and this has been a kind of a vision or a dream of mine to put out a book that was focused on pre-hospital ventilator management for a long, long time. So very excited that it's been perceived so well, and I just want to thank everybody. If you purchased the book in the pre-order session where you got it at a reduced price and you received your book already, everybody should have received their book already. You probably saw a letter that I put in the book. It was probably put in the first few pages. I really hope that you have read that letter and just understand my thank you for purchasing the book and for supporting FlightBridgeED. But I really encourage you to do a review on Amazon.com for me. That really helps me out. On the other books that we've put out, they've been important to me. I think they've helped a lot of people, but this book, I think, is a little bit different for me. I think it's different because I think this is a topic that everybody struggles with. It's an industry issue with all flight companies. And I think the more book reviews we get on Amazon, the more people are going to just go right to that book and buy that book. And I think the book, to me, is a book that's going to help a lot of people. And if it helps people, it helps clinicians understand that topic, then it's going to help patients. And that's my ultimate goal, is to try to provide the best information out there, help you guys become better clinicians. And, that's the whole basis of FlightBridgeED, is to just invest in you. So if you could do that for me, that would be very much appreciative. And I'd be very indebted to you for doing that. I really appreciate that. Like I said, we're going to jump into an article review. This article review I came across, and it was published, it looks like, in July 1st of 2015. So it just came out. And basically what they did is they looked at literature from, I believe, January of 1980 until March of 2015. So they looked at a whole bunch of literature on one topic, which is pretty cool. And they reviewed all that literature, and they came up with some pretty profound, to me, conclusions. So the article review is the use of sodium bicarb in the treatment of acidosis in sepsis. And this is a literature update on a long-term debate. I will publish this in the show notes, so you can pull this up. I'll also put it on the website. And when I say the show notes, this means that you're going to have to actually physically go to the website, go to the podcast on the website, and underneath the podcast, you'll see a link to this article. And I'll probably put it in there as a PDF, so you can just pull it up and save it. And it will be cited as far as where the article came from. I'll also put it on the research section, research and study section on the website, to where you can actually go to that point, or if you wanted to share this with a colleague or a friend, you could easily point them to that area. This is something that I see all the time. We go on calls, flights, or on the ground even, and you come in on a patient that's severely acidotic. They're in sepsis. They're profoundly septic. And, we did a podcast, it's probably been 3 or 4 months ago. Very profound. It was one of our Nightmare Series patients, where it was a patient that was in profound metabolic acidosis. She had arrested before our arrival, and I did a complete podcast on kind of the overall care of that patient. But as we walked in the door, the nurse was actually pushing 2 amps of sodium bicarb. So I kind of wanted to talk about this because I still see this happening all the time, and all the literature is saying that this is a bad thing to do. This isn't something that is new. I know Scott Weingart and MCRIT has taught this for years. I've understood this concept for quite a few years as far as that's not the way you want to do things. You don't want to be treating a metabolic acidosis by just pushing bicarb, and I'll try to explain why that is. Just actually got to go through a lecture by Dr. Kahn, which is a trauma surgeon and a burn surgeon out of Vanderbilt University in Nashville. And we were discussing rhabdo. We were discussing the use of sodium bicarb to alkalinize the urine and the thought process there. And obviously that's taught in all our review classes. That's taught throughout the industry as still one of the uses of sodium bicarb. But he's actually saying that Vanderbilt, which, Vanderbilt's a very respected teaching hospital, very respected medical school, that they're getting away from even giving sodium bicarb in those patients as well, that really optimizing their urine output and diuresing that off is kind of the route that they're taking. Now, obviously, that's one hospital, and I can't confirm that other hospitals are going that route, but obviously they've looked at literature and they're making that decision for a reason. So I just want you to be aware that there are so many different ways to practice medicine. And my job, I feel, with FlightBridgeED is to try to educate you on just what's going on in the industry, put these articles on the website, kind of teach on the concepts of these articles, and then allow you to make your own decisions or take these to your medical directors, share the podcast with your medical director, and see what he or she thinks, right? We're only as good as who we collaborate with. So I'm hoping that by putting out these podcasts like this, that you are able to share this information with other people, and then that's how our practice is going to become better, and that's how our patient outcomes are going to become better. So let's kind of dive into this literature. Obviously, we know that metabolic acidosis in sepsis is a profound thing, and there's a very, very high mortality rate. If you have a patient that is in sepsis, they're in severe septic shock, they have associated hypotension, their mortality rate is around 36%. So that's pretty big. If you couple that with a patient that's sepsis, metabolic acidosis, and they also have lactic acidosis, so that means their lactate level is greater than 4 millimoles, their mortality rate is even higher at almost 50%. It's actually 46.1%. So that's a pretty profound thing. So obviously metabolic acidosis, we know, is defined by a pH less than 7.35. And they're going to have an associated low bicarb. Remember, bicarb is a base. So they're going to have a low bicarb. And most often, based on normal compensation, they're also going to have a lower CO2, right? They're going to attempt to protect that pH. We know that there's a relationship between pH and CO2. For every 10 millimeters of mercury change in CO2, you're going to have an opposite change of 0.08 in your pH in the opposite direction. So your body tries to compensate. We don't want to have such a low critical pH, and the lower we go, our body is going to attempt to compensate by hyperventilation, right? And that's where we see those Kussmaul respirations. That's a big teaching point when we talk about ventilator management and looking at a patient's vital signs and looking at their end-tidal CO2 and identifying, all right, they have an end-tidal CO2 of 20, but why is that? Is it, number one, first, a perfusion issue? Or is it because they're just compensating and they're blowing off so much CO2 to protect that pH? So we have to always be cognizant of why that's happening, and we always have to try to match that compensation. So based on that, we know that a metabolic acidosis is a result of either a increase in hydrogen ions, right, or a decrease in bicarb. So we know also that your CO2 is going to be the biggest initial player in driving up that acidosis, so making that acidosis. So that means lowering that pH down. We know that in a normal aerobic metabolism, we produce CO2 in normal ranges. And we know in anaerobic metabolism, because of the absence of the oxygen in the whole phase, we never go from that glycolysis phase through the Krebs cycle, through the electron transport chain. We stop right after that glycolysis phase, and we again start back over. So we're only producing 2 ATP in the anaerobic phase, but we're also producing a hyperdynamic amount of CO2. So by doing that, that drives down that pH. You also have an issue where in more chronic states that your body will actually develop renal compensation through reabsorption of the bicarb. So the etiology of that essentially is divided into causes related to elevated anion gaps. We know anion gap is filled by lactate, by your ketones, and by strong alcohols. So lactic acidosis is a common cause of high anion gap metabolic acidosis. And again, we know that lactate is made from your anaerobic state, right? Is kind of how we're taught. But we also have to remember that lactate doesn't mean you have profound tissue hypoxia. You know, when I first became a flight paramedic and started kind of dissecting critical care, that's how it was taught to me, was that lactic acidosis or lactate levels that were increased were a complete marker of tissue hypoxia, and that's absolutely not the case. And so obviously, as more research has happened, that they've come to realize that lactate production is a normal thing, that we have to have lactate, your heart has to have lactate, we use lactate, and lactate is a primary fuel for our body systems. So lactate is a good thing, and lactate happens whether we're in aerobic metabolism or anaerobic metabolism. The thing with lactate, though, and the reason why we use lactate as a marker now for morbidity and mortality, more so than tissue hypoxia, like I said, is because lactate and lactate clearance has been shown to basically predict how a patient's going to do. And we know that a normal lactate is about 0.5 to 1. And when you have a patient that has a lactate level of, or I should say, if you have a patient that is in an acidosis, lactate level is going to be around 2.5. And that's where you start looking at, all right, is this going to increase? And so they say that every point increase above approximately 2.5 is a 10% mortality rate when you have associated signs of acidosis. So you have to have that pH that's lower than 7.35. You have to have some signs of hypoxia or anaerobic state to be classified as that. So we know, though, that when you have a high lactate, what causes that high lactate? Because obviously we produce lactate, like I said, all the time. Well, what causes a huge release in lactate is our catecholamine release. And we know that when we're in our initial phases of infection, whether it be a hyperdynamic situation in sepsis, we produce a lot of catecholamines. We have that sympathetic response. We're trying to fight off this infection. Our heart rate goes up. Everything kind of is trying to fight off this infection. So we have this hyperdynamic state, and we release catecholamines. Well, catecholamines, remember, are going to have beta-1 and beta-2 effects. Well, beta-2 effects are what actually release glycogen in our liver. And when we think about the actual process of glycolysis, that glycolysis phase is stimulated by beta-2 stimulation. It releases glycogen. That glycogen actually then converts to glucose. That splits off into the 2-pyruvate molecules, and then we go from there as far as into the Krebs cycle, where we normally would have an oxygen molecule. We produce acetyl-CoA, we produce CO2, and then we convert the NADHs and FADHs that we produce in that process later on in the electron transport chain to ATP. Well, in a situation like this, we're building lactate because of catecholamine releases. It's not only because of an anaerobic state. So because of this huge release in catecholamines, not only by our body's response, but then when they become more profoundly sick and we're giving these pressors, you're going to have a release of catecholamines that are going to actually cause lactate buildup. So that's where we start getting the lactic acidosis. So lactate and lactate clearance is something that we have to think about, and that's what they're going to look at. They're going to continually try to clear that lactate off in an attempt to show a better potential outcome. So normal blood lactate levels in healthy humans, like I said, are 0.5 to 1 millimole, but normal lactate concentrations in patients with critical illness are going to be basically less than 2. When you start seeing that this hyperlactemia or lactic acidosis, that's where you're going to start seeing the lactate levels go from 2 up to the 4, the 5 range. And then when you get above 5, that's where you have this severe lactic acidosis. So why does bicarb produce poor effects? Why do we give, or why do clinicians give bicarb, and why has it always been administered for lactic acidosis? Well, if we think about what hydrogen and bicarb do in our body, they're constantly fluctuating up or down to maintain homeostasis. So if you have a huge amount of hydrogen, which is what we would have in a metabolic acidosis or any acidosis, you would just automatically think, all right, well, if I give and throw all this bicarb, it's going to counterbalance the hydrogen and we're going to correct that issue. But it's not so simple. If you remember the little formula that we always learned in school, right? We have the CO2 plus H2O, then we have the little arrows, and then we have H2CO3, which is carbonic acid, and then we have hydrogen, and then we have plus bicarb. Well, that formula kind of goes back and forth, and that's why we have those arrows that are pointing back and forth. If you think about how we metabolize CO2 in the carbonic acid buffering system, we basically have CO2 and we have water. We know that we have the water that's broke down from oxygen. About 95% of oxygen is broke down into water. We use that in the electron transport chain to convert the NADHs and the FADHs to ATP, but we also utilize that to bind with CO2. So that binding of water to CO2 actually produces carbonic acid, and that carbonic acid is that second-by-second buffering system that utilizes and metabolizes CO2 very, very rapidly. Well, if you think about, and we continue with that, once that carbonic acid is formed, we have to disassociate that as well, and that's disassociated and broke down into either hydrogen and bicarb, right? And so that's how we can metabolize things very, very quickly. It all ends up as hydrogen and bicarb. Well, the same process can happen backwards. If we throw a whole bunch of bicarb, the bicarb is going to bind with hydrogen. That hydrogen and bicarb combined forms carbonic acid. The carbonic acid is going to break down into water and CO2. So, and that's the kind of the teaching point here, is if you give a patient sodium bicarb, not only do you have an increased sodium because this fluid you're giving is now a sodium based, so you have the sodium aspect. It's going to disassociate, and you're going to start having a hypernatremia, right? So your patient's sodium levels are going to increase, but you're also going to have all this CO2 floating around. So in sense, you're throwing bicarb at this patient. You're causing not only fluid shifts because you're giving more sodium. That more sodium is going to cause a hypernatremia. We know that is a osmolar type state. So you're going to pull fluid from the cells. You're going to cause cellular dehydration. You're going to reduce cerebral blood flow, right? That's the kind of the concept that we use when we think about pulling volume off of our brain. When we have cerebral insults, they'll actually cause a hyperosmolar state to pull that fluid off the brain. Well, you're causing kind of the same thing. So are you promoting good O2 delivery? Are you promoting good perfusion to the brain by doing that? And I would say no. In the same context, when you have this situation, is now you have all this CO2 forming, right? Well, we know that CO2 is our driving force in actually dropping our CO2 in the first place. So you don't want to be giving sodium bicarb that's going to cause a increased amount of sodium. Sodium, remember, is an acid. We've talked about this in past podcasts, where sodium, chloride, albumin, those are all acids that affect acid-base balance. So by giving sodium bicarb, you're actually causing sodium levels to increase. Not only are you going to have that hyperosmolar state, but you're going to have a situation where you have more acids there. That's going to affect acid-base arrangements. It's going to cause a worsening acidosis. But you're also going to cause CO2 to increase, which is another big player. So how does that kind of all play into this? Well, the whole rule is that if you think about metabolic acidosis, you need to treat the underlying issue, right? Obviously, source control, attempting to get control of that infection is is the primary goal, and we've learned that throwing broad spectrum antibiotics, gram negative, gram positive, at a infection in the initial stages is probably the best thing, right? You're never going to wait for the cultures. You're just going to throw pretty potent antibiotics at the patient until you get some type of culture back. And then you can focus more on the antibiotic that you feel is going to be based on if it is gram negative or gram positive. But we have to also optimize oxygenation. Now, the whole aspect of lactate and lactic acidosis and it not being a source of true tissue hypoxia, we have to understand that mitochondria, right? Your mitochondria is what is driving active transport in our cells. That's what's driving ATP production. It actually will continue producing ATP at very low levels of O2 delivery. I think all the way down to like 2 to 3 millimoles. So what's that meaning is basically if you had a patient that had a hemoglobin concentration of 2 to 3 millimoles or a hemoglobin concentration down at that low range like that, your mitochondria is going to still produce enough ATP to drive cellular function. So what that tells me is that, tissue hypoxia and poor tissue perfusion is related to a whole bunch of other things, oftentimes probably from poor cardiac output, which we've talked about in other podcasts. We can really look at based on our end-tidal CO2 capnography and indicate how our perfusion status is there. But always early intubation, optimizing oxygenation, looking at your H&H and identifying what your potential delivery of oxygen is versus your consumption. Remember, we can utilize the critical care formula of 1.34 times the hemoglobin times our SaO2. That's going to give you the amount of oxygen we can deliver, and then we can actually multiply that by their cardiac output. And obviously, if you don't have a cardiac output, you can just kind of guess and say, all right, they've got a good hemodynamic status. We'll just use a number of 5. So basically, in a normal person, you can look at them delivering 1,000 mils of oxygen every single minute. That's a huge amount of reserves. Remember, we transport oxygen in 2 areas. We transport oxygen via our plasma, right? 2% is transported in our plasma, and the rest is actually bound to hemoglobin, and we utilize those hemoglobin storages only in the event of stress or exercise, or in an event we need to actually pull those stores for added tissue oxygenation. Well, we also know in metabolic acidosis, we're probably going to be in a right shift in the oxyhemoglobin dissociation curve. And what that means is that your hemoglobin concentrations of oxygen are going to be lower. So your SaO2 is going to be lower than normal. It may be in the mid-80s, but your actual tissue oxygenation status, so your PO2 on your blood gas, is going to be very, very high. So you're getting great tissue oxygenation, you're getting great delivery to your tissues, but your saturation to hemoglobin concentration of oxygen is actually low. Well, we know that's happening because we have a reduced amount of affinity for oxygen binding to our hemoglobin. Our hemoglobin just doesn't want to hold on to oxygen. It now has, remember, only 4 seats at the table. It's got O2 attached, but it also has hydrogen attached. It's got CO2 attached because of our acidotic state. Well, that's not always a bad thing, right? In contrast, if we looked at a metabolic alkalosis, and let's say we converted our patient from a metabolic acidosis to a metabolic alkalosis, that's a very ominous thing. And we know that in that situation, we have a left shift on the hemoglobin curve, where now our affinity for oxygen is going to be very, very high. And that causes a hemoglobin concentration to hold on to all of its oxygen, and it doesn't release it to the tissues. So our SaO2 is actually going to look really, really good on paper, right? When you look at the monitor, your SaO2 may be 97%, but your tissue oxygenation is going to be very, very poor, and your blood gas PO2 may be 40, maybe 50. And so, again, that's where you have to look at this from the big picture, right? Don't just look at the monitor, don't look at the SaO2. You need to understand critical care concepts. So in conclusion, the article goes into a conclusion, and like many articles, it's not going to take a broad stance, but, I think by reading between the lines and reading the whole literature, and again, I encourage you to go on the website and pull this up. I'll read this verbatim. It says, routine bicarbonate administration for treatment of lactic acidosis and sepsis is subject to ongoing debate. Published evidence suggests that bicarbonate therapy is not beneficial in cases of metabolic acidosis and sepsis and may even cause harm by worsening intracellular acidosis. Rational treatment of metabolic acidosis and sepsis is directed towards addressing the underlying causes of acidosis and optimizing tissue oxygenation delivery through optimization of cardiopulmonary parameters. So in the end, we have to look at this from the perspective of what are we going to do? And I think this is one of those things that I look at, and I try to look at things objectively, and I say, you know what, are we just throwing a medication at something and not understanding its full pathophysiology? Something I don't do very often. I got an email the other day by a gentleman named Brian King, and I know he's an avid listener, and I want to give him kudos. He's emailed me in the past, and I get emails like this all the time, but this one just really resonated to me. And one of the things that he talked about was, and I want to thank him for this, is just how he feels that FlightBridgeED has invested in him. Obviously that's the whole goal of my vision of FlightBridgeED, is to just try to make a difference and share information and knowledge with everybody else and help people become better clinicians. And I think we're really easily defined by the culture that we're actually currently in. And I think we all can look around us and we can see people that are negative, that are negative in our organizations, that may feel that they don't need to study anymore, that they don't need to learn new concepts, new aspects of critical care or just emergency medicine. And, they're kind of those people that bring a company down. And, he really feels like adding knowledge consistently and always being that avid learner is important. Obviously, I agree 100%. I've never wanted to stop learning. And I tell this to people that even though I'm just a paramedic, I want to attain a doctor-level knowledge in medicine. Now, obviously, I'm not going to a medical school, but I can surround myself with the best people all the time. I can constantly work hard, ask questions, be humble, and understand my limitations. And by understanding my limitations, that should give you this fuel inside to want to learn more. And then you get the question, and he raised this question in the email of people saying, well, why do you need to know all this stuff? Why do you care about all this extra stuff? And here's why I say you need to know this. When you think about our care, when you think about what we do in medicine, it's not about the procedures we perform. It's not about intubation. It's not about, all these cool things we get to do. When you really get down to it, it's about critical thinking and it's about decision making. And it's about looking at a patient from all angles and making the right decisions and the right calls when it counts. So if you can better give yourself the ability to look at a patient, understand concepts, pathophysiology, and things like that, then absolutely having an MD level knowledge in those concepts, even though you're a paramedic or even though you're a nurse, is an absolute must in my book. Again, it's not about the procedures. It's about critical thinking and decision making that makes a difference. And so that is being a true patient advocate in my book. So I want to commend Brian for the email. I want to thank him for the email, and I want to tell him to continue to work hard. And for all of you out there that I get emails for, and obviously you're listening to this podcast, so you're trying to invest in yourself. You're trying to become better, and I applaud you for that. Keep up the hard work. Always email me if you have a question. That's what I'm here for. My cell phone number is on my email. And again, if you have already done so, you know that you can call me or text me, and I'll answer and return your call and try to give you my time. So again, I want to thank everybody for just making this the most rewarding experience in my life and making FlightBridgeED such a success. We have hit, we're almost at 300% over last year as far as the podcast downloads. We've got listeners in almost 70 countries now. It just blows my mind. And it's a testament to you guys for spreading the word and being loyal and, giving me the courage to continue to try to put out good stuff. So I just want to thank everybody for all you do, and just continue to work hard. And if you have any ideas on podcasts, anything like that, please don't hesitate to email me. Again, like I said at the beginning of the podcast, if you could go on to Amazon and do a book review on the ventilator management pre-hospital perspective, or for that matter, on the fast exam prep book or the our exam prep manual, I would be very, very grateful. So until next time, I want to thank you for all everybody does and continue to work hard, and I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.